Hello, everyone. I'm Michael Soulen. I'm the Director of Interventional Oncology at the University of Pennsylvania Abramson Cancer Center, and I'm happy to talk to you today about navigating liver-directed therapy. So liver metastases, as you know, are super common in patients with neuroendocrine tumors. Neuroendocrine tumors, in fact, are the second most common GI malignancy after colon cancer. So there's a lot of you out there, and patients develop liver metastases about 9 out of 10 times over the course of their disease. It's the most common and often the only site of disease progression, even if there's disease outside the liver, and ultimately leads to death in the majority of NET patients. So controlling them is super important. I'm going to start with biopsy. So, as an interventional radiologist, of course, I do liver-directed therapies, but we also do your biopsies, and this is really, really important in helping us plan the type of treatment that is optimal for you. Because every patient is unique. It's not as simple as you're a PNET or a lung net or a GI net, but there's lots of nuances that are unique to you and your tumor that we can understand by looking at the tissue. So we biopsy everybody pretty aggressively. One of the fundamental things you probably learned about is tumor grade already. So we grade patients as grades 1, 2, or 3, primarily based on the Ki-67 stain of the tumor, which is a stain that helps us calculate the percentage of cells that are growing within the tumor. So on the bottom left, you can see sort of the generic stain of a neuroendocrine tumor, and then the right-hand image is the Ki-67, and all the black staining cells are the ones that are growing. And we count those and determine what percentage are growing, and that gives us a sense of the likelihood that this tumor is going to progress or not. But you have to take this with a big grain of salt. Remember, when they do a biopsy, the pathologist is looking at a teeny little speck of your tumor, not the whole thing. So the sample we happen to get on that biopsy could be a hot spot or a cold spot relative to the remainder of your tumor. So it's not necessarily the most reliable predictor of how you're going to do, even though we do pay a lot of attention to it. I have patients with low-grade tumors who progress sooner than expected. I have patients with higher-grade tumors that sit there and behave very quietly for years. And it just means that the spot we biopsied at that day was not really representative of the whole tumor. And in fact, something that's much more predictive of how the tumor is going to behave is if we look at serial imaging over time. So if we scan you every 3 months, where we're looking at all your tumor and see how collectively your tumor behaves, that's a much more reliable predictor of the likelihood of tumor progression than the Ki-67 is. So just keep that in mind and don't obsess over it. That being said, we do know that the Ki-67 can change over time. So this is a study we did at Penn where we looked at hundreds of biopsy specimens, either from surgery or biopsies, and looked at what happened in individual patients to their Ki-67 over years. And although it's quite a scatter, some patients stay the same, some they went up, some they went down. On average, the Ki-67 number goes up 1% a year. And what that means is if you look at the right-hand box, 30% of our patients had a change in grade on serial biopsies over time. So, the Ki-67 you start with might make you a grade 1 or grade 2, but on the next biopsy, you might be a 2 or a 3. Conversely, it might actually go down, which just goes to show that you had a hot spot one time and a cold spot another. But we do like to rebiopsy patients every 1 or 2 years to see if the biology of their tumor has changed. Another important thing is genetic sequencing. This is not something that was so routinely done in the past for neuroendocrine tumors because they tend not to be very mutated compared to other kinds of cancers. But what we've learned, because we biopsy everybody, is that if you actually sequence people, you learn things that you would not know otherwise. Although not common, it's possible that you have a treatable mutation. So, for example, just this year, I had a patient who had burned through all the standard therapies for a neuroendocrine tumor. I kind of reached the last stage. She was on camposatinib. She was very symptomatic. Her tumor was progressing. But as it happened, I had biopsied her when I treated her, and I got back her genetic sequencing, and it turned out she had what's called a RET1 mutation, a mutation that's more commonly found in lung cancer, and she was thought to have a pulmonary carcinoid. Well, it turns out there's a drug for RET1 mutations, so we got her hooked up with an oncologist who could give her that drug, and now her tumors are melting away and all her symptoms are gone. So, not the most common scenario, but if you're one of those lucky people who has a treatable mutation, you'd want to know that. Also, as we're going to talk about later, there are some mutations that actually help us predict which treatment we should do that would be better for you. So, for example, ATRX-DAC mutations are fairly common, especially in pancreatic neuroendocrine tumors. If you have that, that predicts that you would be resistant to TACE or bland embolization and more sensitive to radiation or TARE. So if we knew that ahead of time, that would help us decide which liver-directed therapy would actually be best for you. So genetic sequencing is super important. You want to ask for that from your doctors when you get biopsy. So let's talk about Principles of liver-directed therapy. This is a little bit of a dense slide, but this is the page from the NCCN guidelines on principles of liver-directed therapy. All the NCCN guidelines have a patient-friendly version, and you can access that for free, and you all should become familiar with this. So this is the one page out of the entire guidelines that kind of summarizes liver-directed therapy, and I'm just going to walk you quickly through the key points. One is, what is liver-directed therapy? So liver-directed therapies can be surgery, they can be transarterial therapies, some form of embolization, they can be percutaneous ablation, where we put a cryoprobe or a microwave probe in and cauterize the lesion, or it could be targeted radiation therapy like SBRT. So why would we do this? So if you have liver-dominant disease that's progressing on a somatostatin analog, octreotide or lanreotide, or is symptomatic despite being on octreotide or lanreotide, or if you just walk in the door with bulky liver metastases where we don't want to risk waiting to see if an SSA would work for you, those are all reasons why you might say, okay, you should get some form of liver embolization. And then the question is how to do that. And there are multiple ways of doing that. So most common are TAE, transarterial embolization or bland embolization, TACE or chemoembolization. And then there's also radioembolization or TARE. And we're going to talk about each of those in more detail. In the big picture, regardless of how we do it, how useful is embolotherapy? How does it help you? Does it control symptoms? Does it shrink your disease? What's the price you pay in terms of side effects or risk? And how long does it last? So control of symptoms is actually what it's best for. 75 to 85% of patients with carcinoid or other hormone-related symptoms from neuroendocrine tumor will have relief of their symptoms after having their liver embolized. If you look at debulking or shrinkage, the response rate is more like 55 to 60%. So a complete response means all your tumor disappears, but partial response, remember, has a very strict definition. It means that if we measure the diameters of your tumors, they shrunk by 30% or more. So if your tumors only shrunk 29%, that's not a response. That's considered stable disease, but that might be enough to make your symptoms go away. So that's why the symptom response rate is actually better than the shrinkage rate. And then in terms of the price you pay, most patients will get post-embolization syndrome, which is this constellation of pain, nausea, vomiting, fevers, loss of energy, loss of appetite that can last from days to weeks. Serious complications happen about 6 to 10% of the time, and almost all of those are just bad post-embolization syndrome that will go away on its own. And then the question of durability, this is an important question because many people think of it, well, you get embolized and how long does that last? But you have to think of liver-directed therapy as a line of therapy. No one would ever give you one dose of chemotherapy and then wait and see what happens, or one dose of PRRT. If we give you one cycle of embolization and you get a great response and it lasts for 1 to 3 years and you progress and you're still progressing in your liver only, we can embolize you again and again and again. So you can get multiple cycles of liver-directed therapy as one line of therapy without necessarily needing to go on to the next best thing. My personal record is 16 times. I embolized one patient 16 times over 12 years before he had to go do something else because it stopped working. So if you look at durability by each cycle, so this is a study from France. They looked at 200 patients that had over 500 embolization procedures, and they had 8 years of follow-up. So the interesting thing was the response rate was the same. So if you responded well the first time, you'll respond well the second time and the third time. What did deteriorate over time was how long the benefit lasted after each cycle. So it was about 20 months on average from the first embolization cycle, but then the second and third each lasted only about a year. But you add that all up, that's like 3.5 years of benefit from 3 sequential cycles of embolization. And in fact, if you looked at the whole group, about a quarter of them needed 5 years before they had untreatable progression and had to go on to the next line of therapy. So that's pretty good for one type of treatment, and sparing all those people needing to go on and fire the next bullet of PRT or chemotherapy or whatever. Of the patients who developed untreatable progression and had to go to a new line of therapy, mostly it's because the tumor just progressed either outside the liver, so they needed systemic therapy, or they progressed in the liver fast enough that they said, okay, this isn't really working anymore, we need to do something else. Only very uncommonly, 6%, was because the repeated cycles of embolization had done enough damage to the liver that you couldn't go back and do it again. So it's rare that we sort of burn the line of therapy due to injury from the embolizations. You usually can repeat them over and over. So now, which technique do you want to use? And as I said, there are 3 major flavors. So there's bland embolization, where we just inject small particles into the artery of the liver and cut off the blood flow of the tumors. So the tumors die because we choked off their blood supply and deprived them of oxygen and nutrients. And that goes back to the 1970s. Chemoembolization is a similar technique, except instead of just injecting sort of bland particles, we make an emulsion. We use an oil-based contrast agent, and we emulsify that with a solution of chemotherapy drugs, and then we inject that until we saturate the vessels of the tumor. So we fill up the tumor blood vessels with this oily emulsion that contains chemotherapy, which we can see on the X-ray image, and then we chase that with a small amount of particles just to cut off the blood flow and trap the emulsion. So that's chemoembolization or TACE, and that's been around since the 1980s. And then finally, we have radioembolization, which is a completely different technique. With radioembolization, we use tiny little radioactive microparticles or seeds. We instill them in the artery of the liver. They sail out in the liver. They get embedded in the tumor, and they radiate the tumor from the inside out, but they don't cut off the blood supply because they're so tiny. So what to do? So we finally have, the NCCN guidelines actually don't distinguish between bland and chemoembolization because up to now, there haven't been any comparative studies. But now we've completed the RETNet trial, which was the randomized embolization trial for neuroendocrine tumors. And for this study, we took patients who had the usual indications. They had liver-dominant disease that was progressive or symptomatic on an SSA or had a heavy tumor burden. It could be any histology, so lung, GI, pancreas. The major exclusion was no prior biliary interventions, no interventions in the bile duct, because that can increase the risk of infection. We'll talk about that shortly. And we took those patients and we randomized them equally to 3 arms. So bland embolization, conventional chemoembolization with oil emulsion, or something called drug-eluting beads or drug-eluting embolics, where the drugs are loaded onto the little microsphere particles instead of using an oily emulsion. And then they were treated, and then they were followed up every 3 months for 2 years clinically and with labs and imaging and assessment of how they felt. So the first important lesson we learned was that the drug-eluting bead technology is way too dangerous in NETs. So we had a safe review after 10 patients to each arm, and the DEB arm was closed because 4 out of the 10 patients had major severe adverse events. 2 ended up in the intensive care unit. 2 had permanent hepatobiliary injury. That picture you see is a CAT scan of the liver with all those black holes or necrotic liver and bile ducts from the drug-eluting beads. 2 had to drop out of the study after the first treatment because of their toxicity. So this confirmed what had been suspected from some prior single-arm studies, that the drug-eluting bead technology was too toxic to be used in neuroendocrine tumors. And in fact, it's already been stated in the NCCN guidelines you should not use this technique. So that left us with just the bland arm and the conventional chemoembolization arm. And these graphs just sort of sum up the final results, which is they work equally well. So the left-hand curve is the hepatic progression-free survival for the tumor to progress within the liver itself. And it was the same between the bland group and the chemoembolization group. The right-hand curve is overall survival. Now that's a little premature because almost nobody dies in 2 years, so it's not very mature data. But again, really no difference in survival between the two groups. And then that bottom curve is what's called the carcinoid symptom severity score. So that's a numerical score for patients who actually have carcinoid syndrome. They have diarrhea and flushing, and we can see that in both arms, that score dropped rapidly over the series of embolizations and then stayed down now to 2 years. So basically, the benefit of bland embolization and chemoembolization was the same. Given that, how do you choose? So when would you choose bland embolization? Well, the most common reason is there are patients who we don't want to give chemotherapy to. So if you walk in the door and you have kidney insufficiency or low blood counts, things that would be made worse by getting chemotherapy, then we're just going to do bland embolization because we don't want to cause other problems based on your risk factors. Sometimes it's the patient preference. There are some patients who just don't want chemotherapy in their body, which is fine. But one thing that's important to remember that we've known from some retrospective studies and also was shown in RETNet is that bland embolization actually has more toxicity than chemoembolization. Most people don't realize that, but the rate of serious adverse events in the RETNet trial with bland embolization was 50% higher than with chemoembolization. And the little data box I'm showing you in the middle is actually from a big retrospective study we did. If we just look at pain, the incidence of pain with chemoembolization or reembolization was around 40%, but with bland embolization was about 70%, significantly higher. And that's because you're using tiny particles and you're embolizing to a much harder endpoint than with the other techniques. So it just hurts more. Even though people think that, if you're not keeping chemotherapy, it must be safer. But in fact, that the opposite is true. Bland embolization is more toxic, mostly because it hurts more. Okay, when to consider drug-eluting beads? Never, right? You should never get these. So if you're consulting with an interventional radiologist who's going to do chemoembolization on you, and they're saying they're going to use drug-eluting beads, walk out the door, call me, I'll find you somebody else. But you should never, ever get these products used for your disease. Now, what about radioembolization? So one of the nice things about radioembolization is it is much less toxic because they're tiny little seeds and you're not cutting off the blood supply. There's almost no side effects. Most people have none. Maybe a third of patients will get some fatigue from the radiation, maybe 10% get nausea, but it's a very well tolerated treatment in the short term. So some people are just too frail to get chemoembolization. You don't want them to get a bad post-embolization syndrome. So if the patient is frail, or if the patient is a caretaker for a family member and can't afford to be disabled, or if there's someone who's employed a job where they can't be off for 2 weeks and lose their income, reembolization is a much less disruptive to quality of life, and so it's good for those patients. Also, as I mentioned before, patients with prior biliary intervention, so you've had a Whipple surgery for a pancreatic tumor or a biliary stent in place, the risk of infection in chemoembolization is quite high because when you've had a Whipple or a stent, the bacteria in your GI tract now colonize your bile ducts. And so when you embolize the liver, you cause injury to the bile ducts, and there's about a 20% risk of an abscess with bland or chemoembolization. If you do radioembolization because you're not actually cutting off the blood flow and causing as much damage, the risk of infection is only 7 or 8%. So anyone who's had a prior biliary intervention, we will prefer to do TARE in. Also, if you're refractory, so if you had bland embolization, chemoembolization, you didn't get a durable benefit, then we'll switch. If you progress in under a year, we just switch to TARE because you're probably one of those people who has a tumor that's resistant to ischemia, but more sensitive to radiation. And in fact, we just completed a study that we're writing up right now where we showed that patients who got TARE in the setting of being refractory to TACE actually had much better benefit in terms of the duration of tumor control than they did with their TACE. Another reason we use it is when we want to combine it with chemotherapy. So some chemotherapy drugs are what we call radiosensitizers that make radiation work better. And it happens that CapTEM, the oral chemotherapy regimen that's commonly used in neuroendocrine tumors, both those drugs are radiosensitizers to make radiation work better. So for patients with higher grade disease, grade 2 or grade 3, especially if there's disease outside the liver that the oncologists want to treat, we will combine CapTEM with Y90 radioembolization and get really, really good results with that. We actually just completed accrual to a multi-center phase 2 study to better understand the benefit of this, but it really seems magical. Another question that comes up frequently is, well, what if I want PRRT? I mean, PRRT is radiation too, right? Would it be dangerous to get TARE and PRRT? And in fact, although that's a very common concern, there is no evidence that that's true, regardless of the order you get them in. The available published data on patients who've had TARE and PRRT in either order is there does not seem to be any increased risk in those patients. To me, that's not a serious concern, but it frequently comes up. However, a real concern is late radiation-induced liver failure. So there are 3 studies from 3 different institutions, including my own, where we looked at patients who had radioembolization and then went on to live for 2 to 10 years later. And it turns out 10 to 20% of those develop late radiation-induced liver failure. So that's particularly true in patients who've had their whole liver embolized. So they needed both sides done. So given that, we try to be cautious and try to avoid whole liver radioembolization and spare a couple segments of liver just to avoid this risk of late radiation-induced liver failure. So that's a little bit of a trade-off in terms of risk that doesn't happen with bland embolization or chemoembolization. And then the other question is, there are all these other therapies out there that you could get that are systemic, such as CapTEM if you have pancreatic neuroendocrine tumor, or PRRT, peptide receptor radiotherapy, Lutathera, which you can get for any kind of neuroendocrine tumor. And these are all approved treatments, and they're all available upfront. So if you fail extrahepatic lanreotide, you are eligible for any of these treatments or liver-directed therapy. And so in some places in the world, people tend to get, for example, PRRT as their second-line therapy, even if they have liver-dominant disease. So how do you decide? Not so easy, but we do have some data. So the NETTER-1 trial, the prospective trial of Lutathera in the United States, had a median overall survival of 4 years, a 5-year survival of about 37%. The trial of CapTEM had a median overall survival of about 60 months or 5 years. We don't have prospective survival data from big trials in bland embolization or chemoembolization, but we do have about 40 years of retrospective data, and it looks like median survival is about 64 months, and even better if you responded well, at the 5-year survival is over 50%. So this would suggest at least that the benefit of liver-directed therapy is comparable or perhaps superior to systemic therapies, and it does make an argument that if you have liver-dominant disease, that liver-directed therapy is the next line of therapy might be appropriate, and we can, in that way, stall time or buy time before you need to fire the next bullet, which might be a systemic therapy like CapTEM or PRRT. And that's certainly how we think about it at Penn. Patients who have liver-dominant disease or localized disease get triaged to localized therapy, whether it's embolization or surgery or whatever, for as long as possible, because someday they're going to need PRRT or CapTEM or whatever, and why fire that bullet too soon? You can save that benefit for later in the course of disease. So I hope you found this summary helpful. Thank you.